Okay, good afternoon, everyone. It is 12 noon, so we'll get started. Welcome to Medical Grand Rounds. Before we begin, I would like to make a brief land acknowledgement. McGill University is on land which has served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which people of the world now gather. Welcome, everyone. It's a great pleasure today to have a speaker well known to many of you. This is courtesy of the Division of Gastroenterology, and I'd like to ask our Chief of Gastroenterology, Alain Bitton, to please present Dr. Mayrand today.
Okay, well, thank you, Nadia. So it's a great pleasure to introduce an esteemed colleague of mine, Dr. Serge Mayrand. We've been around for many years. So just to go back early in his career, Serge completed a research fellowship in digestive disease and motor disorders. That's at the University of Toronto. And he is now director of our Esophageal Motility Laboratory. So in case you didn't know we had one, we actually do have one at the Montreal General Hospital. And he's also co-director of the McGill Multidisciplinary Esophageal Clinic, where he works with the surgeons to give a Mayo Clinic type approach to the treatment of benign esophageal disorders. So he's really well recognized as a Canadian leader in esophageal diseases, esophageal motility disorders, GERD, and Barrett's. So it's a great pleasure to introduce him. Serge is going to talk to us about dysphagia, which is a perfect subject for lunchtime rounds. So Serge, welcome.
Yes, thank you very much, Alain. I hope everybody can hear me. It is a pleasure to be here today, and thank you very much, Alain and Nadia, for this very kind introduction. I'd like also to thank the Department of Medicine for having invited me. For having invited me today to provide a updated review of non-GERD related esophageal disorders that present, of course, with dysphagia. These are my financial disclosure over the last 24 months. And these are CanMed objectives for today. So over the next 45 minutes or so, the objective will be to review first the diagnostic approach to esophageal dysphagia and to understand the principles of current investigation techniques, as well as recognizing the importance of eosinophilic esophagitis as an emerging cause of dysphagia and food bolus impaction, and discuss a little bit the salient features of the pathophysiology, diagnosis and treatment of EOE. Now, I realize that the audience is quite varied, with the various subspecialties and wide array of level of training, going from medical students to more seasoned clinicians. So I hope there will be a little something for everybody. So the first case is I will start with a case presentation of a 40-year-old male who was referred to you for solid food dysphagia. His symptoms started in his teenage years, and reports having dysphagia to solids only, especially dry food, that occurs several times per month. He's always been a slow eater, chews food very carefully, has always never been a fan of swallowing pills, always has to drink while eating, reports occasional heartburn for which he takes occasional antacid, denies any weight loss, he's a non-smoker, no drinker. And his past medical history, when you ask about it, is remarkable for history of childhood asthma. He's not been followed for that recently, and reports having long-standing seasonal allergies to dust and pollen. And 3 weeks prior to his visit to your office, he reports having had a solid food impaction episode after eating a steak, felt that piece was stuck in his middle chest. It happened before, but never quite like that. As sensation persisted, he presented to the emerge at the general. Felt okay otherwise, really, on admission. No shortness of breath, wheezing, drooling. Vital signs were perfectly stable, and his chest and abdominal exams and neck exams were normal. Chest x-ray, soft tissue of the neck was promptly done, and also were read as being normal. The next step was, of course, as these cases happen quite often, GI was called to make an assessment, and then a procedure was performed. But before we go into the details of that case, I'd just like to say make a few comments about dysphagia in general. We all remember from our days in medical school that we can classify dysphagia according to which phase of swallowing is being compromised, either oropharyngeal phase versus esophageal phase of swallowing. Although oropharyngeal dysphagia is a very important problem for all those of you who attend the wards, medicine, and geriatrics, this is a very common issue, and that certainly warrants a discussion, but not today, as I will limit the rest of this talk to esophageal dysphagia. Keep in mind, though, both can occur in a given patient. Esophageal dysphagia is a common condition. 16% of general population is said based on survey experience dysphagia at least once in their life, and 2 to 6% of the population on a more regular basis. So some of them, not all of them, will come to medical attention, but quite a few of them will present. In terms of assessment and history, I'd like just to make a few points aside from the other issue we'll talk about in a minute. But I think in this day and age, and I hope that at the end of this lecture, if someone comes in with dysphagia, there has to be a food allergy history and atopic disorders as well. The other question that I think is important in family history is the presence in the first degree family of esophageal cancer or Barrett's if the patient knows about it. A thorough review of medication may be important as well to clue in as far as what the cause of the dysphagia is. We all know about doxycycline, biphosphonate, iron, NSAIDs, and KCl pill can get stuck sometimes in the esophagus, especially if it's taken without water, and create due to local injury from the mucosa to the mucosa from the pill gets stuck because it's a bit big and create damage or an ulcer at that point in the esophagus, so-called pill esophagitis, will present with severe dinophagia. Dysphagia rarely leads to stricture, and the management of this, of course, is based on endoscopic finding. It's more of an acute phase. Another thing I'd like to mention about drugs is the use of chronic opioids. Of course, we're in the middle of that opioid crisis now for several years. And we know that opioids chronically will affect a variety of function in the gut as well from a motor point of view. What's not that much recognized is these patients may present with an increased incidence of dysphagia. And when these patients were studied, they have 2/3 of them with chronic opioid with dysphagia will present a fairly significant abnormality on the manometric tracing, either type 3 achalasia, distal esophageal spasm, hypercontractile esophagus, EGG outflow obstruction. So much that the term opioid-induced esophageal dysfunction has been coined to characterize these patients. The thinking is that there are mu kappa receptors on myenteric plexus in the distal esophagus and the lower esophageal sphincter, which leads to dysregulation of the inhibitory enteric nervous system. So that's also something to think about if the patient has been chronically on opioids. Their dysphagia may be related to a motor dysfunction. Now, before we get into a bit more the analysis and the workup of these patients, of course, one of the things present with dysphagia, particularly the obstructive type, we have to be concerned about neoplasm. These are the alarm signs that should prompt maybe even a faster referral to GI. These criteria are outlined in the most recent guidelines on dysphagia from the Canadian Association of Gastroenterology. So older patient anemia, odynophagia, profound weight loss, and regurgitation and vomiting may give us some clue as to the urgent nature of the problem. To that, however, I'd like to add the following, particularly in the context of patients with chronic severe reflux who present with dysphagia. Of course, it may represent a peptic stricture, but we have to keep in mind the risk factors for adenocarcinoma in these patients. Male gender, Caucasian race, central obesity, past or present history of smoking, and have all been linked to a significant increased risk of adenocarcinoma in chronic refluxers. Something that is not as well known, however, but this has been shown fairly recently, is a confirmed history of Barrett's or esophageal adenocarcinoma or esophageal cancer. Patients may not know what type of cancer their relative had, but should be referred. This will confer an increased risk of possibility of neoplastic as a cause. Risk factor for the other type of cancer, squamous cell carcinoma, keeping in mind that adenocarcinoma is more frequent now than squamous cell carcinoma, which is traditionally associated with smoking, drinking, past caustic injury, achalasia, and rare things like Plummer-Vinson syndrome and tylosis. So when you have a combination of these factors, particularly in the context of chronic reflux who presented dysphagia, I think this has to be considered for being fast-tracked. That being said, how common is it that we're going to find cancer? Well, in patients with presenting dysphagia, well, it depends who you ask for or where you look. Retrospective data from North Carolina shown a prevalence of cancer in dysphagia between 4 to 6%. That's sky high. That's pretty high. But if they focused their cohort, the increased risk was strongly associated with male gender, weight loss, and age greater than 50, which kind of highlights the importance of the risk factor. However, if you look in a more cross-sectional population study, less than 1% had cancer. However, this is not to be taken lightly. Unfortunately, in this day and age, in spite of all the advances, the 5-year survival of esophageal cancer, all stage included, is still a dismal 16%. And early recognition might be important because early stage of disease will perform better. This is the classical algorithm, if you will, the way we all learn in medical school how to approach esophageal dysphagia. First, to say, well, the first question is it solid only, solid with liquids? Keep in mind that in my experience, it's not always that quick and dry, to be honest. But if you have solids only, you have to think of an esophageal structural problem. If it's progressive over a period of time, particularly if it's associated with chronic heartburn, you have to think of stricture or esophagitis. If, however, it is more rapid, weight loss, profound cancer has to be along with the risk factor I've mentioned. If it's more of an intermittent nature, then you think of something like more benign esophageal ring webs or eosinophilic esophagitis, as we'll see in a few minutes. If, on the other hand, symptoms with solids and liquids, well, it makes sense that, if liquids involve motor dysfunction can be that, but I've seen plenty of motor dysfunction present with solid only dysphagia, so it is not absolutely specific. If, however, it is the case, then if it's progressive chronic heartburn, you have to think of scleroderma absent contractility versus regurgitation and vomiting being associated more with achalasia. Presence of chest pain may make you think of a hypertensive disorder of the esophagus, such as distal esophageal spasm. So this classic framework is still useful, I think, to think about it, but in practice, I am not so sure that it is that helpful. The message, I think, however, because it is blurry, more blurry than we'd like to think, is the patients have to be worked up, and the workup, the common pathway is essentially the same. So for all intended purposes, in the appropriate patient, of course, all patients with a history of esophageal dysphagia should first be referred for an upper endoscopy with biopsy. High-resolution endoscopy, white light, remains the gold standard and the first approach. Is it always readily available? That's another issue. We can talk about that later. Other tools at our disposal to investigate these patients, or barium study or time barium study, high-resolution esophageal manometry, which allows us to study the abnormalities of primary peristalsis, which is triggered, this peristalsis that is triggered when we all eat or drink. More recently in our lab, we have access to a new technology called EndoFlip, which is endoscopic functional lumen imaging planimetry, which is demonstrated on this panel right at the bottom. And this is different from standard manometry, as it allows us to assess the biomechanical properties of the esophageal wall, particularly distensibility and compliance, as well as abnormality of secondary peristalsis, which is triggered by a artificially barred balloon. And this is what has opened a new front. I won't discuss this much further, but we'll talk about high resolution and barium study. Now, barium cineesophagogram is still a useful tool. Part of the problem has been described as a dying art. It is not easy to get our radiologists sometimes interested in this kind of testing a bit more. They're very busy in cross-sectional imaging and MRI and PET and all that. But unfortunately, I'm very happy to say that MUHC is at the forefront of that, so we still have good barium data, barium swallow being done. However, one has to understand that the overall there is a limited sensitivity and specificity compared with endoscopy, especially when we try to assess mucosal detail. For sure that endoscopy is unbeatable compared to a barium contrast study standard for mucosal disease. There's also limitation in the fact that when you think of it, it's very subjective interpretation of barium study. There's a lack of standardized criteria, terminology, and normative values. For example, and I get, again, today, my nurse called me in the morning, a doctor sent us a referral because a patient had dysphagia, had a barium swallow, and said tertiary contractions. I think, what does it mean? It doesn't mean very much. And again, it is not to disparage our radiologist colleague, but people have looked at that. And tertiary contractions, for example, means not much. It's poorly predictive of motor dysfunction in itself and can be seen in normal in older patients, at least above 40. So we have to, it's still useful, I will say in which context, but we have to recognize the limitations of it. And as I said, I think the role of in patients who've had a normal endoscopy, normal histology, with esophageal dysphagia, and you suspect maybe a motor dysfunction, that might be somewhere to start though, because it's readily available. It's not very costly and not dangerous to the patient, and can give you useful information if it's very, very normal. That's pretty good, or very, very abnormal and stage achalasia. But in between, the test can be normal or abnormal. It's not going to be tremendously useful, but I think it's still a tool that can be used. Recognizing these limitations, I think the people have tried to see how can we get better information from the contrast study, which is, the good way to assess transit. So in order to have a better, more objective measurement of transit, we now talk about, we have available time barium swallow. A very simple test indeed. They give a cup of low density barium with maybe a little barium pill if you have solid dysphagia, and they take a film at 1, 2, and 5 minutes upright, measure the height and width and cross-sectional area of the residual barium column. And criteria suggests that it is abnormal if you have more than 5 centimeters at 1 minute and more than 2 centimeters at 5 minute barium retention. And when the people looked at that critically, it was highly reproducible, a lower intra and inter observer variability with a much higher sensitivity and specificity compared to high resolution manometry. And this is just show what is done, very simple. And the patient gets the cup of barium, and you just take a film at 1, 2, and 5 minutes, measuring the height of the barium column. This is an example here of a patient with distended esophagus, classic bird's beak appearance in achalasia. And you have here at 1, 2, and 5 minutes, the barium of columns is 5 centimeters and doesn't move. So clearly marked retention. We have to keep in mind that the usual transit in the esophagus for you and I for a normal is 8 to 10 seconds. So 5 minutes retention in that height is very abnormal. So this will give you a clue and allows us also to follow patients pre and post treatment. This is such an example in patients with a achalasia, again, distended esophagus, that bird's beak appearance. You get the kind of narrowed G junction here and dilation above, but post-op, post-laparoscopic heteromerotomy, the whole barium column empties nicely, and that tells us that the patients had a good results. Some patients do not have that, some they have retention, and you have to kind of ask yourself what's going on, and maybe patients may need further treatment. This is not a complicated test, but it takes some dedication from the radiologist. And I'm very happy and very recognizant to our radiologist here at MUHC, especially Dr. Artho and his colleagues, to have taken this and do this. So many clinics, private clinics don't do this. Many hospitals, other hospitals have not or stopped doing barium swallow altogether. But if you provide esophageal, service for esophageal patients, I think this is absolutely essential. And you can ask it, just pay time barium swallow, they will do it. Now, moving on here along the line of investigation, let's talk a little bit about manometry. The barium test will give us some information and it's part of the workup, and time barium swallow I do in every patient who I feel needed. But sometimes it's not enough. The barium swallow can be normal. It's not necessarily that sensitive for that matter. And we have to rely on more specific and more sensitive technology. High resolution manometry is such a technology. And this technology allows us to measure the pressure, the peristaltic activity in the patient. For a patient, this is the probe that we use here, which has multiple transducers, solid state. This is introduced transnasally, a weight in an awake patient, of course, brave patients, this is not necessarily an easy test. And it allows us through this computer system to have a 2D representation of a swallow. If we move here to the left, to the right side, you may remember this from medical school again, or more recently, where the patient swallows, and this is just the peristaltic wave that comes along the length of the esophagus to push the bolus downward. This is so-called line tracing, which was the standard of care until 10 years ago. But now we've moved totally to high resolution and a Doppler-like representation, which integrates a number of variables. Just to orient you, if you've never seen this, this is the pharynx, upper esophageal sphincter. This is the thorax with the esophagus. Of course, we're in the esophagus, lower esophageal sphincter, and the stomach. It allows us in one shot to scan the whole esophagus with this technology, while the patient is given some bolus to swallow either apple juice or Gatorade. And a number of metrics can be measured along that line. Without going into details of this, but just to show what a normal example would be of a normal esophageal manometry, this is again the pharynx, upper esophageal sphincter, esophagus, cardiac artifact a little bit. You see respiration as well, and this is the stomach. And what you see in purple is apple juice, actually, because we have the ability through this technology to detect change in impedance. So we're able to do a kind of an electronic barium swallow. So we can assess not only motor function, but also bolus transit. And here the patient is asked to swallow, the upper esophageal sphincter relax, the bolus passes through very nicely because of gravity into the stomach, and the lower esophageal sphincter opens to let it through. And on the heel of, on the tail of the bolus, the peristaltic wave comes downwards. So we're able to do a whole bunch of measurements and metrics. And this technology has been around now for 10 years. But I think technology is important, of course, but technology for the sake of technology has its own limitation. In this case, I think that the advent of high-resolution manometry has led to a revolution in the understanding of esophageal motor disorder. And this is best exemplified by the advent of so-called the Chicago classification of motor disorders. This is the fourth iteration of this disorder, and this is this complicated algorithm that is shown here on this slide. We're not going to go through that, obviously, but the principles are important. Chicago classification is a multinational consensus conference that were able to, based on high-resolution data, establish normalization, that is standardization of how to proceed, how to interpret tracings, and what to make of it, and in order that we speak a uniform language across the board in terms of patient selection for trials, as well as for clinical management. So this is being refined every 4 years, but has been a real revolution in that field. And just to very briefly, if we concentrate first on the two extremes, first the left-hand side, that is to get through this algorithm, you get to these nice inserts, and we now distinguish two big groups of motor disorder. That is on the left-hand side in orange, so-called disorders of esophageal gastrojunction outflow problem. And you have in this category achalasia, and we now recognize three subtypes of achalasia. I'll talk about this in a minute. And EGJ outflow obstruction, so that is kind of failure of relaxation of the sphincter with normal peristalsis, while achalasia is characterized by absence of relaxation and absent peristalsis. Completely to the opposite, on the right-hand side in the green group, you have pure disorder of peristalsis, which now recognize four major motor disorder: absent contractility, that we will see often with the advanced mixed connective tissue, scleroderma, sometimes in lupus; distal esophageal spasm, hypercontractile esophagus; and finally, ineffective motor dysfunction that you see with reflux. The definition of that is not important for today, but just to kind of understand that we now have this way to categorize disorder and everything in between, so that we speak the same language. Going back on motor dysfunction for a minute, I've mentioned that achalasia is now recognized as having three types. Achalasia, for sure, this is something that you've come across, although it's not a common disease. It affects maybe 3 per person, incidence of 3 per 100,000. You might see a lot at MUHC because we see quite a few, but it's still a rare disease. It's not a new disease. It was first described in the 17th century. We still don't know what causes it, by the way. We think it could be related to a autoimmune inflammatory response to early exposure in genetically predisposed individual, early exposure to a virus. And that leads to a inflammatory plexus an inflammation of the myenteric plexus that specifically involved the enteric inhibitory nervous system in the enteric system, in the myenteric plexus in the lower esophagus or sphincter, preventing relaxation. So what characterized the achalasia is an absence or incomplete LES relaxation and absent peristalsis, therefore causing dysphagia. And as I mentioned, we now recognize three types, type 1, 2, 3. Type 2 in the center is probably the most common, and the type are been described based on the phenotype that you see on manometry, on high-resolution manometry. And type 2 is the most common thing associated with these kind of longitudinal muscle contractions. The criteria here are not important, but they're all characterized by lack of LES relaxation. Type 2 might be an earlier form of the disease, respond the best to treatment, best to all treatments, while type 1 may be a more advanced form of disease, those that have that distended, dilated esophagus. Finally, type 3, fortunately, is the rarest form, only 10% of patients, more associated with chest pain, more difficult to treat as well with our current available treatment. I don't have time to discuss in details achalasia further, but treatment options include Botox injection. It allows the LES to relax. We do that commonly in patients who may be too frail to have more definitive therapy. All the forms of therapy, by the way, for achalasia, you have to think of this as a progressive neurodegenerative disorder of the inhibitory myenteric plexus specific to the esophagus. It doesn't affect anything else anywhere in the gut. In itself. So all therapy, we cannot regenerate the inhibitory nervous system. So we have to disrupt the sphincter. And we do that through balloon dilatation, per oral endoscopic myotomy, the new kid on the block. So basically doing a myotomy, but through endoscopy. And finally, laparoscopic heleromyotomy indoor, which has been around for longer. I'm happy because all these techniques are available to our patients here at MUHC for all the cases that we have. Now, in the meantime, let's not forget our patients in the ER. I told them I was presenting around, so they had to wait a bit. So it was seen by GI, and after consent was obtained, an endoscopy was performed. So remember, young man, footballers, impaction. That's the story. Now, this is not the patient, by the way. This is just to show people who've not seen endoscopy recently what a normal esophagus may look like. A little fluid, little, normal esophagus, pearly white mucosa with a little bit of vascular pattern. This is beautiful, normal esophagus. But when we put the scope in, this is what we saw. Something a bit alarming, I would say, in this case. Again, if you've never seen this endoscopy, but this is a very marked abnormality, very narrow caliber esophagus, multiple rings. You see this actually are exudates or micro abscesses in the esophagus, and this has been likened to trachea. So the old term was trachealization of the esophagus or felonization of the esophagus. In my prior life, I scoped many cats. So, those cats have a very pronounced smooth muscle impression on this in the esophagus, and therefore will look a little bit like this. But this is fixed, multiple ring and web, and you see here a little mucosal disruption because the food bolus had to be pushed down the esophagus. And biopsies were done, and this is what it showed. Patients' biopsies came back 2 weeks after, and the pathologist, and you see a very thickened epithelium and replete with these red cells. And pathologists reported squamous mucosa with erosions, basal hyperplasia, intercellular edema with more than 90 EOs per high-powered field. So consistent with eosinophilic esophagitis. What is eosinophilic esophagitis, or EOE? Well, it can be defined as a chronic, progressive, allergy-driven type 2 immune-mediated inflammatory disease. characterized clinically by symptoms of esophageal dysfunction, particularly dysphagia, and histologically by eosinophilic predominant inflammation. And without going into all the details today, but this is just a very simplified schematic of what is happening, or so we think. So in genetically susceptible patients exposed to a variety of environmental exposure of food allergen, the epithelium will send a distress signal by so-called alarmins, TSLP or IL-33, and this will lead to a type 2 inflammatory response by recruitment and stimulation of T helper cells to produce a variety of inflammatory cytokine, namely IL-5, IL-4, and IL-13. And all of those conspire to cause the disease, among other things. So IL-13, for example, will play a role in weakening the epithelial membrane, the epithelial barrier, as a defense mechanism against further intrusion by allergens and other bad things. IL-4 will stimulate iotaxin 3, which is a very potent recruitment is a potent chemoattractant of eosinophil, while all of them with IL-5 will also promote recruitment of inflammatory cells, granulocytes, including mast cells and basophil, which will, through degranulation process, favor collagen deposition and thickening of the lamina propria. And all this together will cause a bad esophagus that does not contract properly and leading to dysphagia. These things in the blue squares are different pharmacological target that have been proposed, and I will discuss a little bit later, dupilumab, and of course, proton pump inhibitor. And over time, this is what we think happens. Patients have, let's say, normal, then inflamed, and over time, there's a thickening of the collagen table along with inflammation, progressing from inflammation to fibrosis, more fibrosis, going from children to adults, and possibly causing the obstructed picture we saw on our patient. Now, there is obviously a clear association between eosinophilic esophagitis and allergic comorbidity. In fact, it's been reported that up to 70% of patients with EOE will present either allergic rhinitis, asthma, atopic dermatitis, and IgE-mediated food allergies. Now, in reverse, patients with those disorder, especially as teenager or infancy, patients who may have comorbidities and IgE food allergies have a greater risk of development of EOE over time. Now, people have suggested that this is a paper from Hill a few years ago, that EOE would be can be considered as a late member of the so-called atopic march, which goes from one disease to next and then end up with EOE, having as a common pathway this dysregulation of type 2 immune response. Now, EOE is rare. Achalasia, described first in the 17th century, but achalasia is recent. First description was in the 1990s. The first patient I saw and treated with dilatation, this was before EOE was ever described. I didn't know what he had. I just dilated him and he got better. And we figured it out, I guess, later. 70% of these patients are males, so strong male predisposition, and Caucasian more common. There's also a familial incidence. It's not rare that sons and father and sons, or even daughters and father, will have the disease. Now, the incidence here, this is a population study and has been increasing in incidence. Of course, it did not exist, we think, before 90s, but I don't think it did. And of course, it's been rising across several areas. The prevalence also is increasing because it's a chronic disorder. It may be a bit of a recognition bias. It's more common in North America and Europe, with an overall incidence of 5 to 20 and prevalence of 10 to 60 per 100,000. And this is above and beyond this increasing in EOE of new cases is above and beyond the increasing number of endoscopy. So again, this is not only a recognition bias, there is an increase. So you might see that in your own practice, especially if you do emergency work. This is data from our colleagues in Calgary. And if we look at all food bolus impaction in the ER, this was from Calgary, EOE will account for at least 35% of all food bolus impaction. But, you have peptic stricture rings, peptic esophagitis also as potentially causing this problem. But here, 15% of these patients in that study were reported normal, but the authors acknowledge that many of them may not have been biopsied. So you don't know, because you can have normal endoscopy looking, but still have EOE on biopsy. It's not very common, but it does occur. And maybe the incidence of EOE as a cause of food bolus impaction is probably higher than this, and has been reported so in many studies. How does it present? I just talked about dysphagia as being the hallmark feature in adults and teenagers, or older patients as well. But it's more than that, because this is a chronic disease, and patients will habituate themselves. They will not necessarily be very forthcoming about these symptoms. I'm not talking about over-medicalizing these patients, but we have to ask about dietary modifications, speed of eating, chewing, and so on, and in order adapt so-called adaptive behaviors. And the little acronym here, impact, may be useful to remember. So does the patient have to drink a lot, modified food consistency, prolonged meal time, avoid hard food, chew a lot, turn away tablets? So those might be clues that something is wrong. Heartburn, yes, refractory heartburn, reflux, chest pain, but without dysphagia, I think this unlikely to be EOE. What I talked about today is mostly about adults and kids, or very young kids and young teenagers. Failure to try, feeding intolerance, reflux, abdominal pain, nausea has been reported as well. So the manifestations are not as clear. And we think it's because at that time, they're still in the inflammation phase and haven't strictured their esophagus enough to cause dysphagia. But this is some degree of speculation. How does one make the diagnosis? Well, first you have to suspect it and then refer the patient for an upper endoscopy with biopsies. All patients, this is not a clear part of guidelines. Anybody with dysphagia with endoscopy, if it's abnormal cancer, of course you biopsy it, but even if it's normal, should be biopsied to rule out EOE. 6 to 8 biopsies, the more the better, because you increase your yield, 2 sites, and target presence of exudates or abnormalities. So you have to do a good high-quality upper endoscopy. And the magic threshold is esophageal eosinophilia, that's a mouthful, greater than 15 per high power field or 60 per millimeter square. Now, once that, you're still not finished, because even if you have this threshold, you still have to think, could this be caused by, because there are some non-EOE disorders that may cause or potentially contribute to esophageal eosinophilia. It's been described in a variety of conditions, particularly reflux. That's the big confounder. Because of the inflammation caused by reflux, it may attract some EOE. Just keep in mind that EOE in the normal esophagus does not exist. EOs are never in the esophagus unless something is happening. So GERD, achalasia, Crohn's disease, graft versus host, different other conditions may be a differential diagnosis that you have to address before or exclude before you call this eosinophilic esophagitis. Now, going back to achalasia, which I mentioned earlier in the talk, it's been known for quite some time that we can find eosinophil on biopsies in achalasia. And it's our own data from a few years ago where we looked in 96 of our patients and this was published a few years ago by Jonathan Pools, and we looked at our patient, and 34% of our patients with achalasia, this was a pre and post-op cohort, but 34% had EOs on their biopsy with a various range with a median of 3 per high power field. So not very high infiltration, but still abnormal. But when we looked at that, 8% reached the threshold criteria for EOE. Now, there could be a confounder, but these patients had classic achalasia, abnormal barium swallow, abnormal manometry, although this was carried out before the advent of high resolution, but they all had evolved as achalasia. So we were sure or very convinced that this was a reflection of inflammation or reflux, that this was just not more than that. But 2 weeks ago, a very challenging paper, a very provocative paper got published, at least as far as I think, paper from the Stupler's group in Texas, and looked at it's a population-based study of 844 patients with achalasia. Keep in mind, achalasia is rare, but they found 844 in their population study. And when they asked, do you have allergic disorder? 48% of them had one or more allergic disorder, and 7% of them on biopsy or had also a diagnosis of EOE that was made either before or after the diagnosis. Although it's a population study, it's retrospective, there are some issues with that data. They looked at the relative risk of EOE in achalasia versus what would be expected in an adjusted population versus what would be expected. The odds ratio was 33, and the relative risk was 33. And if you selected young patients, the relative risk was even higher. So what are we talking here? Is this is there a connection between the two? Are we talking allergy-driven or allergy-associated achalasia-like motor dysfunction, or EOE presenting as a typical achalasia or a typical achalasia presenting with EOE? Now, this study may not be representative of the whole population as a group, but it certainly raises interesting issues about whether or not some patients with achalasia may have feature of EOE or vice versa. Some EOE may have feature of achalasia. So this just brings the point that the diagnosis have to be carefully thought about and require sometimes maybe a little bit more of investigation. Keeping in mind that vast majority, we're talking about two separate things, achalasia versus EOE, two separate things. But in the middle, who knows, more to follow. In the last few minutes that's remaining, I'd like to talk about what do you do with these patients. And we have several tools at our disposal nowadays. Endoscopic dilatation, diet therapy, PPI, yet again, yes, we know we like PPI, topical corticosteroids, and biological agents. I'll talk briefly about dilatation. Of course, if the patient, like the patients we just saw, if the scope can be passed, if they have bolus impaction, I do believe that these patients should be offered dilatation at the earliest possible time. I won't go into the details of that. This is done endoscopically, variety of techniques. This has been detailed recently by the SG guidelines on endoscopic approach to eosinophilic esophagitis. It's got to be done carefully. You don't bring a tiny caliber esophagus to something normal quickly, because you may end up perforating the esophagus. But this is certainly something that is part of the treatment algorithm. Now, I've said earlier on that food allergen triggers this disease. So we know from pediatric data in the very early days of EOE that if you put the children on a strict elemental diet for days, months, even years, believe it or not, that their symptoms will get better. Indeed, it's very effective. But who can or would be on elemental diet for the rest of their lives? Not many. So the people have been able to sort out which kind of common food allergen could be involved in triggering this disease. And this has led at the adoption of the 6-food elimination diet: cow's milk, wheat, egg, soy, peanut, tree nuts, fish, and seafood. And people have gone on these diets and shown improvement, and then you can reintroduce the food one by one, trying to tease out which one is the culprit or which combination of food. This is not so easy to do as you may imagine. So people say, okay, 6 is hard, let's go to 4. And 4 was hard, and they say, okay, well, what about the 2? And finally, people say, well, what about if we just do one food? Which one would cause the most likely culprit? And cow's milk was in that group. We now have data based on systematic reviews of meta-analysis of the effectiveness of dietary therapy in EOE. As I've mentioned earlier, not practical strategy, but elemental diet will get you better, but maybe not very happy. 6 food, not as good, that's histologic remission, but pretty good, but still not great. Last year, however, we have data now comparing the 6-food elimination diet versus the 1-food elimination diet, meaning animal milk. This is a well-carried, very carefully done randomized control trial on 129 patients assessing histologic remission as an endpoint. And they found that the 6-food, you have 40% histologic remission, EOs below 15 versus 34 in 1-food. So not as bad, but there was no statistical difference. So this has led to some change, because in these patients, when they're seen in the office, we can propose fairly early on, well, do you like milk? Do you have a lot of milk? Why don't you go do you want to try to go on milk, all animal milk-free diet for 8 weeks or 12 weeks, and then see if it works? It's not very complicated, and most patients will give it a try, although the rate of response may not be the highest, but it's worth giving it a try as part of what we can suggest to the patients. What about PPI? I mean, GI, we like PPI, don't we? Well, PPI, of course, has anti-reflux effects to helping restore the epithelial barrier function, which may be damaged in EOE. But more than anti-reflux or antacid, it also has a direct anti-inflammatory effect by binding to STAT6 and eotaxin 3 promoter, which promotes eosinophil attraction and reduce eotaxin 3 eosinophil migration. You can use either single or double dose. There's no placebo-controlled trial, but several case control studies and have shown effectiveness of PPI ranging from 30 to 50% histologically versus symptomatic remission. So the second line of option is probably to put them on a PPI, especially since they may have mild reflux. It's covered by insurance. It's widely available. And it's one reason, by the way, sometimes we think about de-escalating PPI or reducing PPI for maybe improper indication. But that is one, I believe, that if the patient is on it for EOE and has respond, may need long-term maintenance, it should not be stopped or reduced because patients with symptoms will recur. If that doesn't work, what about topical steroids? It's been around for a while. We used a swallowed fluticasone nebulizer, basically the pump. They were told not to inhale it like you do in asthma, but to swallow it. Didn't work that well, I think, practically speaking. We then resorted to oral viscous budesonide, basically taking a Pulmicort ampule, just cracking it. The patient mixed it in a teaspoon with 5 grams of Splenda or honey. Not very worked. Data supported it, but for the patients was not the most user-friendly strategy. Very recently, though, 2 years ago in Canada and a week ago in the States, budesonide specifically approved a formulation for EOE came to the market in oral dispersible tablets, and the dose being 1 milligrams BID. This is the pivotal trial that led to its approval in Canada. This is the Lucendo trial published a few years ago with active eosinophilic esophagitis in adults. This was a 6-week trial of BID budesonide, and if you focus on the first panel here, forget the rest, but they had a clinical and histologic remission endpoint, and the rate of response was 60% versus 0% in the placebo at 6 weeks. EOE is a chronic disorder. We know that patients who respond to treatment, the rate of relapse is very high of treatment. So they extended that study up to 52 weeks, 48 extra weeks, this time comparing after dose 0.5 to 1 versus placebo, and they were able to maintain 3/4 of patients of the responder maintain their remission at 1 year versus 4%. Then, other endpoints were highly significant as well. One might be concerned about long-term use of budesonide. Suspected and confirmed candidiasis of the esophagus was found, but did not alter treatment. AM cortisol also had very little impact on them. Keep one thing in mind: if patients have multiple allergies, they're taking oral topical corticosteroids, I would be more concerned about their inhaled steroids, because we know that this is more likely because of the absorption from inhaled or nasal Avamys or whatever, what have you, will be much higher, and those may cause more problem than the oral GI budesonide. So just to keep that in mind if they're on both, as many patients might be. So these therapies are useful. They're not perfect. And keeping in mind that the disease is a type 2 inflammatory disorder, why not try biologics for EOE? Well, indeed, they tried. Patients refractory to PPI or steroids approximately represent 40% of the group. They may be intolerant. They may also have other comorbidity that may be benefiting from biologics, and it'd be easier to improve compliance in terms of taking. Several biologics are being studied now. I will talk about the only strategy that has currently been successful so far and available. Dupilumab, which is a fully humanized monoclonal antibody blocking the shared receptors between IL-4 and IL-13, had been approved in the past for a variety of immunologic disorder, of atopic disorder, and only approved in Canada, however, for EOE 11 months ago. So this is a very new kid on the block as well. without going into all the details, but this is the pivotal trial that led to the approval at the FDA level for dupilumab in EoE. And they basically, in a group of patients, randomized dupilumab to placebo, regular dose, and then went on to observe a longer form of the study at 52 weeks. And then they compared in a separate arm of the study, high dose, that is once a week injection versus every 2 weeks versus placebo. These were patients who were active EoE, all refractory to PPI. And as you see here, as an outcome, histologic remission, EOs less than 6 bar high power field at 24 weeks, dupilumab once a week, much better than placebo. If you give it twice a week, still pretty good, about the same, better than placebo. And everybody at 52 weeks who were put on the active drug did well. This is histologic remission, so very good. In terms of symptoms, mean change in dysphagia score questionnaire, at 24 weeks, then again, dupilumab was much better than placebo, but that's the higher dose once a week. In the every 2 weeks patient group, they did not reach improvement in symptoms, much different from placebo. And there might be reasons for that I can explain later, but is a bit above the description here. But this is what led Health Canada, because only the 300 milligrams once a week reached the combined endpoint of histologic remission and symptoms improvement. There's some limitations to that because we do not have head-to-head trials versus steroids. It may require long-term maintenance. It's not cheap. So it may be better suited for patients who may have multiple atopic comorbidities or refractory to standard treatment. And that brings me to the conclusions for today. So dysphagia remains a frequent problem in clinical practice, requiring clinical investigational tools as well as multidisciplinary approach, as we'll see in a second. Several technological advances, high-resolution manometry, impedance planimetry, have led really to a better understanding of the esophageal dysphagia and a more rational standardized classification of motor dysfunctions. EoE is an important cause of dysphagia and food bolus impaction, especially in atopic individual with an increasing incidence. So we have to think about it. I think in the proper patient, high index of suspicion is essential to establish a early diagnosis. Finally, management of EoE, when again, I started my first patient 32 years ago, we had, besides dilatation, nothing to offer, really. We didn't know what it was. And that's greatly evolved in the last 3 years, really, more therapeutic options than before to help these patients. So dysphagia in 2024, is it an allergic disorder? Well, sometimes, but not only, because these patients may also have other problems, GERD, reflux, and so on. So it's got to be worked up in its proper form. However, as you saw from this talk, I'm certainly not an immunologist, allergist. I'm not a surgeon either. So it takes a village at MUHC to take care of these patients. So I'd like just to give a shout out to our Esophageal Esophagitis clinic program and the importance of co-management of these patients between GI and immunology, because they have a strong allergic background that needs to be managed, as well as their esophageal disease. I learned so much from my colleague in allergy and immunology, and I thank particularly Dr. Tardio and Dr. Fine for their help and support, and we have this program now in place here. I'd like to thank also my colleagues in surgery for the esophageal disease program, and in thoracic surgery as well, without forgetting my nurses. The nurses in GI works with me in the Esophageal Motility Lab to make it happen. So I think I'll stop here, and we have a few minutes for questions. Thank you very much for your kind attention.
Thank you very much. Really, really interesting talk, Dr. Mayrand. Fantastic topic. We don't hear about this very often. Very interesting, comprehensive talk. I invite people to ask their questions. I have a question to start. You know, in cardiology, we talk about nitrates. And, you know, if people have chest pain and could be esophageal conditions, usually we talk about esophageal spasm, which will respond to nitrates. Does this respond to nitrates at all?
Yeah, that's a good question, Nadia. For sure, nitrates will cause, relax the smooth muscle of the esophagus just as well, will relax the lower esophageal sphincter. However, I think we have to make two distinctions. Patients may present with chest pain as their symptoms, but they may not necessarily have a recognizable motor dysfunction. And in reverse, the motor dysfunction may be present, but may not necessarily be linked to the symptoms. So in someone that may have both, yes, it probably is worth trying. The data, randomized trial on that, or data that we have, is not very strong in terms of its efficacy as a strategy. I think, although it sounds countersensical, and you'll say we kind of hammer the same nail all the time, but many of these patients who present with chest pain, I'm not saying all of them, but some of them, they may have an effective motor dysfunction, and it'd be more a reflection, believe it or not, of reflux. So treating reflux might be a more useful strategies in these patients, particularly before considering workup. Of course, if they been on PPI already and so on, but it may be worth a trial in these patients, because reflux, which I'm not talking about today, but is very, very much more common and can present and be the trigger for the motor dysfunction.
Fantastic. I'm just looking here. There's a question on PPI duration and RAMQ funding. I guess they're referring to, there is a limit. Is there some sort of code, I guess,
Yes.
now that limits you? So how do you get around that in this condition? Because you did say something about sort of long-term PPI.
Yes, you're absolutely right. You have to understand the two issues. One is we use PPI, of course, off-label for that indications, because they don't have their indications. But for a variety of conditions that requires long-term, for example, Barrett's and EOE, achalasia, but certainly EOE as well, you can use the long-term code 999. So the conditions have been listed because we made representation at the government level. So if they have a known diagnosis of EOE, Barrett's is part of that, many other things, achalasia, and then they will be reimbursed without concern. So the 205 code is for persistent symptoms without any diagnosis, particularly diagnosis. So if patients for reflux, but 999 would be the code I use. I haven't had any problems so far, and I would defend it. I would defend anybody
who uses that code. Okay, that's good.
But for EOE, I would certainly. Yes.
Okay, fantastic.
I'll go
Why
to the
is there such an increase in EOE?
That's a good question, and I think I don't know if some of the immunologists are on the call. I know Dr. Tardio had another meeting, but I think it goes along with the increase in allergies, in the general population. I think it's following that trend. Is it environmental factors? What is it that triggered that? But I think there's a correlation between the increased incidence of allergic disorder, particularly food allergies, in the general population, and that goes along with this. We don't have a clear. More than that, at least I don't know what to say. And again, 1990. I don't think I don't think it existed because people were scoping patients well before. Since the 1970, endoscopy was around and readily available, and this characteristic appearance on endoscopy would have been picked up in the 70s and 80s for sure, and never was. So.
Interesting. There's a comment here about atopic dermatitis and asthma. Does the dietary, I guess the food elimination, help in that? Should we be looking for food elimination in patients who have these persistent symptoms?
That's a good question, and I'm afraid that's why I made the disclaimer on just before my last slide. I'm not an immunologist, allergist, so I don't think that. But I can't comment.
Serge,
Natasha is there.
I was here the
whole
time.
Go ahead. Yeah. Yes, please go ahead.
I attended your talk. Yeah. So, sorry, to answer the first question, it's correlating. The significant increase in EOE is correlating with the significant increase in all atopic conditions, asthma, atopic dermatitis, and we do believe there's an increase in epithelial cell defects. And we know that patients that have epithelial defects or mutations in epithelial defects are more at risk of eczema, EOE, since we're sensitized through the esophageal epithelium. So we're really seeing this, and it's becoming quite significant, including food allergies in general, like anaphylactic type food allergies. To answer the second question, we don't see that diet elimination would be effective in asthma and eczema the way it is in EOE. So we actually don't do, food allergy skin testing for actually any of these conditions, including EOE, since usually we do empiric diet elimination in EOE, but we especially don't do it just to treat asthma or eczema unless the patient has an anaphylactic type, an immediate type of reaction to a food. So we don't usually do, like diets or food allergy testing if the reactions to foods are delayed, as in the case of EOE.
Fantastic. Very interesting. Go ahead, Serge. Go ahead.
Thank you very much. You see, Nadia, and all that, why combined approach
Yes.
is so important. And I've learned so much
Yeah.
from my allergist, immunologist colleagues. I'm very happy that they're here with us.
Fantastic. We have time for one last question. Somebody is asking, thank you so much, Natasha, for that. Somebody is asking about myomectomy. Is this done in the by endoscopy, or does this require surgical intervention?
Good question. And both. Heller-myotomy and dorsal fundoplication through laparoscopic is done surgically, but POEM is done endoscopically. So rather than doing laparoscopic and operating from the outside, making the cut, now we can, through endoscopic, go inside to make a tunnel into the wall of the esophagus without any laparoscopic or abdominal incision and make that cut. It still requires anesthesia, but this is something that is performed now at MUHC. We're one of the only centers we offer everything. Very fortunate, but it's done by gastroenterologists. Here it's done by one of our minimally invasive surgeon, but we certainly have the expertise within our walls with Dr. Chen and Nadia. I'll do a push. What limits the approach by GI in this context is sometimes access with anesthesia. So, but I'll leave it at that. But we're certainly, ready to run and offer, because we do have Yanni Chen and one of our visiting professor coming next year, as you're aware, Dr. Jacques from France, able to do those. So that's, but it is another tool in our box that we can offer, because some patients may do better with the endoscopic approach than with surgery. Those type 3 I talked about, they've been doing better with the POEM. So we have to be able to offer this.
Fantastic.
Well,
first of all, congratulations on putting this whole team together. Really, really interesting presentation, and so great to hear that the MUHC will have a team like this. And yes, I think these procedures done out of the OR suites by the medical people are only going to grow in time, and we do definitely need more. I'm with you. We definitely need more access to these kind of procedures. Congratulations. Really great talk. Very, very interesting. Thanks everyone for joining us. And thanks, Natasha, for comments as well. Have a great day.
Thank you.
Thanks. Bye-bye.
Bye-bye.